right, welcome to our presentation today. Go from beginning. Okay, our December EMIC meeting. Um, if this is your first time, welcome. My name is Leanne Lowenthal, and I am the Senior Manager for Immunization Initiatives at the Partnership for Maternal and Child Health of Northern New Jersey. If you are not familiar, EMIC, or the Essex Metro Immunization Coalition, is a group of concerned community organizations, medical professionals, and advocates dedicated to increasing timely and age-appropriate immunizations. Today, we have a presentation. It's an overview of childhood vaccines and strategies for dealing with vaccine hesitancy. And as always, at the end of the meeting, we give attendees the opportunity for community announcements. So please feel free, let us know what's going on in your community, introduce yourself at the end of the meeting. Let me advance our slides. So now I'm going to hand it over to Dr. Schwab to approve our September meeting minutes and introduce our presenters.
Okay, thanks, Leanne. So I'd like to welcome everybody also to the meeting. Hope everybody had an enjoyable Thanksgiving and is getting ready for the holiday season coming up. One order of business before we get to the presentation is we do need to approve the September minutes. So those have been sent around, and I think it's in the chat. Is that right, Leanne?
Yes, you should be able to see the meeting minutes in the chat.
Yeah. So if you want to take a few minutes or just a minute to review those, and if anyone has any corrections or additions to the minutes, please let us know. Otherwise, we'll take a vote in the chat to approve them. Just yes or no to Leanne.
So if we could get a motion to approve the minutes, if you just want to motion in the chat or say yes.
Thanks,
Thanks, Emily.
Emily.
And Eva,
Okay,
thank you.
we've got a second. Okay, so you can just yay or nay in the chat.
All right. You've got some yeses. Thank you. Dr. Schwab, we are ready. We've approved the minutes. I think we're ready for introductions.
Okay, very good. So
Thank you.
before I introduce our speakers, I do also have a couple of procedural things to go through regarding our disclosures and the continuing education. Um, so first of all, the speakers and planners for this educational activity do not have any relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. And there is no commercial support for this activity. And then for continuing education, this program is approved for one contact hour. The Partnership for Maternal and Child Health of Northern New Jersey is approved as a provider of nursing continuing professional development by the New Jersey State Nurses Association, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. Approval status does not imply endorsement by the Partnership for Maternal and Child Health of Northern New Jersey, by NJSNA, or by ANCC of any commercial products discussed or displayed in conjunction with the educational activity. To receive contact hours for this continuing education program, each attendee must attend the entire program and complete and submit a post-program evaluation. A certificate of completion will be distributed electronically within 2 weeks of receipt of the complete evaluation. And so I'm happy to welcome our speakers today to speak to us about pediatric vaccines, a topic near and dear to all of us. We have two speakers who are going to be working together. Dr. Shivani Patel is a resident physician at Newark Beth Israel Medical Center in the pediatric residency program affiliated with RWJ Barnabas Health. And our second speaker is Rohan Ublikar, who's a medical student in his fourth year at Rutgers, New Jersey Medical School. So I'm happy to welcome both of you, and we are looking forward to your presentation. So I'll mute now and we'll get started.
Thank you so much, Dr. Schwab, and thank you everyone for joining us. Before we get started, I also wanted to thank Dr. Uzma Hassan, who's in the meeting right now. She is the Regional Director of Pediatric Infectious Diseases in Northern Jersey, RWJBH, and a Clinical Associate Professor at Rutgers, New Jersey Medical School. And she was very involved in mentoring us through creating this talk and will be helping to answer any questions in the chat. And just to reiterate, we have no financial disclosures for this talk. So here's an outline of the talk. We'll start by talking about general vaccine science, then move on to specific vaccines and the illnesses they prevent. Finally, we'll talk about vaccine hesitancy and strategies to address it. So what are vaccines? I have the scientific definition up on the slide, but the long story short is that vaccines are educational materials for the immune system. They're a way to teach our bodies to fight infections without experiencing all the dangers of illness. And once the immune system gets that education, it can make its own cells and antibodies to prevent infections for a long time, sometimes for life. And this is what's called active immunity. Vaccines have been around for a long time. This picture on the right shows Edward Jenner, who invented the first vaccine against smallpox. Since then, vaccines have saved over 150 million lives, many of those from infants and children. They've completely eradicated smallpox around the world, and they've made many other infectious diseases far less common and deadly than they once were. So there are many types of vaccines that we give to children. This graphic from CHOP is really fun, and it covers all of the vaccine types used in children. First, we have live attenuated vaccines, and these are weakened viruses that cause little to no symptoms, but that the immune system will learn to fight off just like the real thing. This type of vaccine is really effective and tends to provide long-lasting immunity because the immune system gets to practice against something close to the real thing. And then next we have inactivated vaccines, and these vaccines use killed viral particles that can't replicate or cause even a mild infection. And these vaccines work very well and they're easy to produce, but they may need periodic boosters to maintain the immunity. And then we have subunit vaccines, which comprises many different types in of itself. They use part of the virus or bacteria rather than the whole thing. And this includes recombinant vaccines, which just means that the subunit is produced via an organism such as a yeast before being purified, as well as conjugate vaccines, which are when the subunits are proteins and polysaccharides that are bonded together to create a stronger immune response to the pathogen. And regardless of the type, subunit vaccines often need booster doses to stay effective. And similar to that, we have toxoid vaccines, which use a neutralized toxin that's produced by a bacteria to protect directly against that toxin. This is a very effective type of vaccine, especially at neutralizing toxins, but they do often need periodic booster doses. And finally, we have mRNA vaccines, which contain a blueprint for a protein that's found in a virus. The patient's cells manufacture the protein, and then the immune system reacts to that product. It's important to note that the mRNA, the blueprint, it does not enter the host genome in any way, and it does not alter the patient's DNA. And currently, the only mRNA vaccines we have are for COVID-19. And just to reiterate, all these vaccine types are safe and effective. They all act as different ways to teach the immune system to fight infections. And here we can see those many different vaccine types represented in the pediatric immunization schedule. As you can see, the majority of vaccines are started by 1 year of life, and that's important because, as you'll see, many vaccine-preventable illnesses affect young children the most. The schedule is carefully developed to minimize the time where children are vulnerable to those diseases and maximize the effectiveness of the vaccines. So we'll be going through this schedule in chronological order, so hopefully you'll get to see how that's the case. Apologies for my cat. Before that, I just wanted to make a few notes about the vaccine side effects. As vaccines are given to healthy children, we're very serious about monitoring side effects, and they're constantly reported and studied before a vaccine is licensed and after. Fortunately, the vast majority of side effects from vaccine are minor, things like injection site pain, redness, fever, fatigue, irritability, headache, so things we've all experienced. What we really worry about are things that lead to the hospital. And one universal risk for any kind of treatment is that a child will have a serious allergic reaction or anaphylaxis. Luckily, that risk is very small with the vaccines, about 1 in 1 million. And of course, if a child has a severe allergic reaction to any vaccine, then it's not given in the future. Also, with the live attenuated vaccines that we discussed earlier, there is an extremely small risk that the weakened virus can replicate and cause asymptomatic infections in people. And for that reason, some very specific patients, like pregnant people and people taking certain medications, they can't take those vaccines. But in the vast majority of situations, live vaccines are completely safe, and we even make sure that people are up to date with them before becoming pregnant or starting to take those medications to keep them protected from the real infection, which would be much worse. Finally, we'll go over some specific side effects related to certain vaccines on future slides. But one of those I did want to make note of is febrile seizures. And this is a very common event in childhood where a child has a fever, experiences a seizure, I'm sure you've heard of. While it seems very scary, the vast majority of febrile seizures are benign, and they seem to be related to a genetic predisposition. Fevers associated with vaccines can occasionally cause febrile seizures, and certain vaccines can cause febrile seizures at a slightly increased rate, such as the combination MMR and varicella vaccine, which we'll discuss later. Regardless, the chances of a vaccine causing a febrile seizure are low, and nearly all of those events result in no long-term harm to the child. So important to keep in mind. Now we can start going over vaccine-preventable diseases with hepatitis B. And this is a virus that infects liver cells. It's spread via bodily fluids and from mother to child during delivery. And the chances of that vertical transmission from mother to child are very high. Hep B is also highly contagious in the community because it can live for days on surfaces, and even slight exposures of infected blood to an open cut or wound can result in infection. And this is especially bad for kids because they tend to develop a lifelong infection without adverse symptoms. And that chronic inflammation from the virus leads to horrible outcomes later in life, like liver failure and cancer. And actually, chronic Hep B is a leading cause of liver cancer worldwide. Even in the US, there are many people living with chronic Hep B, and because it's asymptomatic, many people don't know they have it, which leads to an increased risk of transmission. And just to highlight that, here's a heat map from the NJDOH showing cases of Hep B in New Jersey. And this just goes to show that the virus is in the community and the risk of infection is real. But thankfully, we do have a vaccine to prevent it. So the Hep B vaccine is a recombinant subunit vaccine. And it's special in that it's the first vaccine given to children in the US. And it's usually at birth and then at 2, 4, and 6 months. Many people ask why we have this universal policy of Hep B vaccination at birth, rather than trying to just target maybe infants born to mothers who have Hep B. And we did have a risk-based policy in the 80s, but unfortunately, the cases did not go down as much as we'd hoped. And there are cases where mothers will contract the illness between screening and having a baby, or where an infant will be infected after birth by someone caring for them, as the virus is very contagious. But since implementing universal infant vaccination for Hep B, cases in children have dropped by 90%, which is incredible success. I've even seen 99% in some sources. Moreover, the Hep B vaccine is extremely safe with only the tiny risk of allergy. The full course is very effective in producing immunity to the virus, which is important because, as we saw, the virus is very, very contagious. So overall, the Hep B vaccine is a big success story, and it's very important to have a universal policy of infant vaccination against this disease so that we can prevent long-term complications like liver cancer down the road. And next up is rotavirus. So this is a virus that causes diarrhea and vomiting, which can be absolutely devastating in infants, especially in places around the world that can't easily hospitalize them or give IV fluids. And for that reason, because it was so common, rotavirus claimed hundreds of thousands of lives every year before the vaccine was introduced, and unfortunately still does in many places that can't access the vaccine. The vaccine we have is live attenuated. There's two formulations. They're given at 2, 4, and 6 months of age. Both the formulations are given as drops via the mouth, and side effects are mostly mild stomach upset and irritability, so mild symptoms of the infection. You may have heard of the side effect called intussusception, which, as you can see pictured on the right, is when part of the bowel folds in on itself and causes an obstruction. And this is obviously a serious condition. But the risk of this happening with the rotavirus vaccine is extremely small. And we do avoid this vaccine, though, in children who had the condition before. because it can occur with many other viral infections, including rotavirus itself. But moving on, we have poliovirus. This is a very famous virus that has a wide range of presentations, from a mild illness to the lifelong paralysis. And you can see on the right a child who's confined to an iron lung to breathe from him because of paralytic polio. Unfortunately, there has been a vaccine for decades. There's a live attenuated virus and an inactivated vaccine. We used to use the live vaccine in the US. However, in extremely rare cases, the weakened virus would cause paralytic polio in immunodeficient hosts, so people with compromised immune systems. So in the early 2000s, we switched to the inactivated vaccine, which is given at 2, 4, and 6 months, and then at 4 to 6 years. And this carries absolutely no risk of paralytic polio, and it's overall extremely safe. And these vaccination efforts have all but eliminated paralytic polio in the US, which is another amazing public health success story for vaccines. And then we have Haemophilus influenza type B, or HIV. And this is a bacteria that was known for causing horrible disease in children. So things like meningitis, infection of the tissue surrounding the brain, pneumonia, sepsis, infection of the blood. And you can see the effects of HIV sepsis on the right with the child who has gangrene from a reaction to the bacteria in their blood. And then you have epiglottitis, which is, you can see on the bottom, where part of the airway is so inflamed that it blocks off the vocal cords. And these illnesses could all be deadly, especially under the age of 2 years, with HIV meningitis carrying a very high fatality and complication rate. And epiglottitis, of course, was an emergency that required immediate intubation, as you can see in the image where the person is intubated. Now, though, we do give the vaccine to prevent these illnesses, and this is a conjugate vaccine, so a type of subunit vaccine given at 2, 4, and 6 months with the booster at 12 to 15 months. It's very safe, and it really has cut down cases of this bug in children, which is wonderful. Then we have Streptococcus pneumoniae, or pneumococcus, which is another bacteria. And this is a major cause of illness in children and adults, including things like pneumonia, meningitis, and ear infections, as well as bacteremia and sepsis. And it's a deadly disease in children, especially with meningitis and sepsis, but it's also a common cause of death in the elderly. The vaccine is another conjugate vaccine that protects against 20 serotypes of the bacteria, so 20 subgroups. And like HIV, it's given at 2, 4, 6, and then 12 to 15 months. There is a very small increased risk of febrile seizure when this is given with the inactivated influenza vaccine, but it's a very safe vaccine overall, and it has massively reduced cases of invasive pneumococcal disease in children. And as the science progresses, we'll be able to vaccinate against even more serotypes to provide more complete protection against this bacteria. So there's new vaccines coming out in the future. But next we have 3 bacteria that have a combination vaccine available. So diphtheria, tetanus, and pertussis. And all 3 of these are bacteria. Diphtheria infects the throat with something called a pseudomembrane and releases toxins into the body that result in severe illness and even death. And you can see on the right a child whose neck is very inflamed from diphtherial infection. Tetanus lives in the soil and it enters the body through wounds, releases toxins into the body, and they cause these horrible muscular contractions, as you can see on the right. And tetanus is a brutal and very deadly illness, although thankfully it's fairly uncommon. And then we have pertussis, which is also called whooping cough. And this is an extremely contagious respiratory bacteria that causes these fits of coughing called paroxysmal coughs. The airway inflammation causes a whistling sound when breathing in after a coughing fit, which is why it's called whooping cough. These fits can be really severe. They can cause vomiting and even broken ribs. And you can see on the right a child with broken blood vessels in his face and eyes from coughing so hard. And pertussis is a very bad vaccine-preventable disease because it hits young infants very hard. And unfortunately, outbreaks still occur in the US. Just in November, there was a 3rd infant death reported in Kentucky over the past 12 months. So it's a very relevant illness even today, which is why vaccination is so important. So we give infants and young children the diphtheria, tetanus, and acellular pertussis vaccine, or DTaP. There's also a Tdap shot that has the same components in different amounts that's given at older ages. And this is a combination toxoid and subunit vaccine that protects against the tetanus and diphtheria toxins, as well as containing parts of the pertussis bacteria. And it's given at 2, 4, 6, and 15 to 18 months, and then again at 4 to 6 years. We also give the Tdap every 10 years after that as a booster. And importantly, because pertussis is so dangerous to newborns and infants, pregnant women are also given Tdap so that they can pass their antibodies to the baby to provide some temporary protection before the infant can be vaccinated. There are some adverse reactions associated with this vaccine, and One that might come up is the significant local swelling you can see on the right, which is also called an Arthus reaction. And this looks dramatic and it may be painful, but it does go away with time in antihistamines. The vaccine can also cause higher grade fever on occasion, and there is again a slightly increased risk of febrile seizures when this is given with the inactivated influenza vaccine. There were more side effects associated with the older whole cell version of the pertussis vaccine, including rare cases of something called encephalopathy, where a child would have a strange behavior like crying for a long time after vaccination. That hasn't really been shown to be associated directly in the acellular vaccine, but if something like that happens within a week of a previous dose of DTaP, then the pertussis component is avoided in the future just to be safe. Still, this is overall a very safe vaccine and has dramatically reduced cases of all of these diseases. Pertussis especially used to be very common, and the vaccine is about 80 to 85% effective in providing immunity. Unfortunately, sometimes that isn't enough, and it's part of why there's still a significant number of pertussis cases in the U.S. today. And in 2024, the cases more than tripled to 35,000, with 10 deaths, and 6 of those were in infants. While the majority of those affected had unknown or insufficient vaccination status, 25% were fully vaccinated. Vaccination reduces the risk of infection. It also helps to prevent severe disease and death. But we rely on widespread vaccination rates to keep this bug from spreading and hitting children who are susceptible. And as Dr. Patel will show you, places where vaccine exemptions are more lenient are being hit the hardest by whooping cough. And with a deadly, highly contagious disease like pertussis, widespread vaccination really is the only thing we have to prevent outbreaks and reduce the severity of disease. Then moving on to another respiratory illness, we have influenza. So this is the flu, which we all know causes the classic fever, malaise, respiratory, and GI symptoms. While we don't traditionally think of the flu as a serious illness, it can be severe in both children and the elderly. Influenza actually causes the most hospitalizations of any vaccine-preventable disease, and it has several serious complications that can be life-threatening, including to the heart, brain, and lungs. Fortunately, we have the flu vaccine. There are actually different formulations of the influenza vaccine with inactivated and recombinant injected forms, as well as the live attenuated form that's administered nasally. Both the inactivated and live attenuated forms are manufactured using chicken eggs, but they've been shown to be safe in people who are allergic to eggs, so they can still be given. And the flu vaccine is given yearly ahead of the flu season, with children over 6 months eligible to receive it. And the very first immunization should be followed up with the second dose after 4 weeks if the child is 8 years old or under. And the vaccine helps to reduce symptoms, hospitalizations, and deaths from the flu in children, and it's very safe. As I've mentioned, there is a very low risk of febrile seizure when this is given with some other vaccines. And there are very rare reports of something called Guillain-Barré syndrome, which is a temporary autoimmune paralytic condition. Guillain-Barré is triggered by viral illnesses, and the risk is about 100 times greater with flu infection than with the vaccine, where the risk is consistently about 1 in a million each year. And unfortunately, the 2024 to 2025 flu season had 280 pediatric deaths, which is the highest number in a non-pandemic season. A bit less than half of these children had no underlying conditions, but almost 90% were not fully vaccinated. So it's really important to understand that the flu vaccine does reduce the severity of disease and it saves kids' lives. Okay, next we have measles, mumps, and rubella. So measles is a virus and it causes cough, profuse runny nose, and red eyes with the characteristic rash you can see on the right. And it's incredibly contagious, one of the most contagious diseases known to humans. And about 2 in 1,000 cases are fatal. 1 in 1,000 can involve the brain, which can include long-term complications. Of course, younger children and the immunocompromised are at the highest risk. And then we have mumps, which is another virus that causes salivary gland inflammation that you can see on the right. In boys and men, it can also frequently cause testicular inflammation, which is called orchitis, and that can result in lifelong sterility. And it can also have multiple life-threatening complications in different organs, including the kidneys, liver, heart, and even brain. And then we have rubella, which is also called German measles, which is a virus that causes severe congenital disease. It's highly contagious, but in most cases are mild. However, if a pregnant person is infected, then they can pass the infection on to the baby, which results in this really severe congenital syndrome with complications like blindness, deafness, heart defects, growth restriction, and autism. And you can see an infant with this condition on the right. And to add on another virus, we have varicella zoster, which is commonly known as chickenpox or VZV. This causes that classic rash you can see on the left, and children will generally recover on their own from this. But with all these pustules on their bodies, kids with chickenpox are at increased risk for skin and soft tissue infections, which could be deadly. Also, the virus lives in the nurse for life, and they can reactivate when the immune system is weak or in old age, which causes shingles. And you can see the local rash and shingles on the right, and that's associated with severe nerve pain, and it can linger past the outbreak. Children with a weakened immune system are at very high risk for severe disease with VZV, and it can also cause a congenital syndrome. So definitely a serious illness. Fortunately, there are vaccines to prevent all of these diseases. MMR vaccinates against measles, mumps, and rubella, and it's a live vaccine that's given at 12 to 15 months, and then again at 4 to 6 years. It's very safe, but there is a slightly increased risk of febrile seizure with the first dose only. There are also some reports of transient drops in platelet counts with this vaccine, which is generally benign and goes away on its own. We do avoid this vaccine in people with compromised immune system because it's a live vaccine, as I mentioned earlier. But in the extremely rare cases where it was given, there have been a few reports of encephalitis similar to what measles can cause in a natural infection. But you can see that this vaccine has really dropped the cases of these illnesses, which used to be very common in the US and unfortunately are starting to crop up again. The varicella vaccine is also a live vaccine. It's given at the same time as MMR, and we similarly avoid giving this vaccine in people with compromised immune systems. Even in healthy children, the vaccine strain can occasionally cause symptoms like a mild chickenpox rash. Very rarely, it'll cause a milder form of shingles. But overall, this is a very safe vaccine that has dramatically reduced chickenpox cases in the US, where it used to be something that almost every child got. And I just wanted to note that there is a combination vaccine, which is called MMRV. This is associated with a somewhat higher risk of febrile seizure in the first dose only than MMR alone. So the vaccines are often given separately for the first dose, then combined for the second one, although it can be kind of a shared clinical decision between the pediatrician and parents. And of course, we had to talk about the recent measles outbreaks. So this year, since I pulled the numbers, there have been 1,798 cases and 3 deaths. 92% of cases occurred in people who are either unvaccinated or with unknown vaccination status. Measles is extremely contagious, and there are no antiviral treatments. Vaccinations are really the only effective strategy we have in preventing these outbreaks and deaths. And we need rates to stay above 95% in the community to prevent spread. So moving on, we have hepatitis A. So this is another virus that affects liver cells, and it can cause a prolonged up to 2 months large outbreaks. It isn't generally deadly, but it definitely stings to be sick and miserable for so long, which is why the vaccine became recommended throughout the US in 2020. And this is a killed virus vaccine, and it can be given either at 12 months and then again 6 to 18 months later, or it can be given in combination with the Hep B vaccine according to that schedule. And like Hep B, this is a very safe vaccine with extremely rare serious side effects, mostly anaphylaxis. And then we have HPV. This is a family of viruses that essentially causes warts, which can affect the skin, like the palms and the feet, and then can also affect the mucosa, so things like the mouth and genitalia. That's important because genital HPV is an extremely common STI, and many women will get cervical HPV at some point in their lives. In most, that's no issue. It's asymptomatic and the virus will clear away on its own, but in some women, the virus will linger and it will progress to cancer. And this is responsible for about 90% of cervical cancer in the US, as well as a number of other cancer. And in fact, it causes nearly 100% of head and neck cancer as well. So the vaccine is a recombinant vaccine that protects against 9 subtypes of HPV that often cause cancer. It's given after age 9 in 2 or 3 doses, depending on when it started. And it's very safe overall, though it is associated with some benign cases of fainting after the first dose. And it really has had an amazing effect on the rate of cervical, head, neck, and other cancers. And you can see that the HPV vaccine has dropped the number of cervical precancers by 80% in 20 to 24-year-olds. And CIN3 plus is the point at which you're guaranteed a procedure. So this is really making a big difference in preventing these cancers that can absolutely claim lives. Next, we have meningococcus, and this is a bacteria that lives in the nose, but it can cause extremely deadly disease. So things like meningitis and bacteremia, which you can see on the right with this poor child who has gangrene of the extremities from the bacterial sepsis. Meningococcal disease is extremely deadly, and even survivors can have lifelong complications. It can also occur in outbreaks that affect people living in close quarters, so like college students in dorms, military members in barracks, and prisoners. And people with certain immunodeficiencies are at very high risk from this disease. So there are two vaccines. One is a conjugate that covers the A, C, Y, and W135 serotypes, and a recombinant type that covers the B serotype. And these can be given together as well, but the ACYW is generally recommended at 11 to 12 years and then after age 16. And the MenB is usually given between 16 and 23 years, often when people go off to college or things like that. And while this disease isn't super common in the US, it is terrifying and deadly, so it's reassuring that we have vaccines to prevent it. And finally, we have COVID-19, which we all know. Just to give some brief points, SARS is often mild in children, but young children are still at risk for hospitalization and even death. Also, there are serious complications, including to the lungs, brain, and heart, as well as things like long COVID and multi-system inflammatory syndrome, which you can see on the right involves multiple serious complications in different organ systems, and requires at least hospitalization. The mRNA vaccines are approved for children on an opt-in basis, and it has a very safe side effect profile. There are very rare cases of myocarditis, so heart inflammation from the vaccine, but it's much rarer and milder than from the actual disease. The risk is mostly in teenage boys. And the thing to keep in mind is that almost all children hospitalized with COVID were not up to date with the vaccine. So it really does make a big difference. And all right, so that's all the pediatric vaccinations. We did it. Thank you for listening so attentively. I will turn it over to Dr. Patel now to talk about vaccine hesitancy.
Thank you, Rohan. So now moving on to pediatric vaccine hesitancy. Vaccine hesitancy is one of the top global health threats. It threatens decades of progress in preventing vaccine-preventable diseases and increases the risk of outbreaks. Tackling it means clear communication with parents, educating communities, engaging locally, and supporting strong public health policies. WHO defines vaccine hesitancy as delaying or refusing vaccines even when they are available. It's not always outright refusal. Sometimes parents just space out doses, which still lowers protection. Even with the national high vaccination rates, hesitancy is very common. CDC data shows that 1 in 5 children have parents who report some hesitancy. The WHO's 3Cs model from 2015 helps us explain why parents hesitate to vaccinate. One being confidence, worries about safety or efficacy, misinformation, or just historical mistrust. Second could be complacency, thinking vaccine preventable diseases aren't a big risk. And third is convenience. Practical barriers like cost, access, time, or transportation do play a role. This is an image that highlights that a lot of other factors play a role in why families hesitate to vaccinate. Things like unclear communication from providers, influence from peers or communities, preference for natural immunities, and worries about the ingredients of vaccines, or getting too many shots at once can all make parents pause. Social factors here matter too: lower income or education, limited access to healthcare, and getting exposed to negative content on social media can shift families towards hesitancy. Even social networks and political polarization can shape how parents think and whom they trust. So, overall, these combined influences make vaccine hesitancy feel more familiar and safer to families than vaccine acceptance. A lot of anti vaccine arguments come from misinformation. People claim vaccines have toxins, cause autism or autoimmune issues, or overload the immune system. The internet and media amplify these messages. Most people check online before making health decisions, and misinformation spreads easily. Anti vaccine websites often cite themselves or give no real evidence, and emotional personal stories can seem more convincing even if they are false. Media coverage that politicizes vaccines can erode trust in doctors and reduce vaccine support. When the decision is in politicized, support for vaccines tends to rise. Once a vaccine myth spreads, it's hard to reverse. Repeating false information, even to correct it, can actually make the myth stronger, a phenomena called the backfire effect. People tend to remember the myth more than the correction. And then misinformation is often emotional and memorable, so simply sharing facts isn't always enough to change perceptions. Vaccination rates are also affected by state exemption policies that I'll talk about in the next slide. As Rohan mentioned before, studies show that purchases rates were more than twice as high in states that allow personal belief exemptions. US states allow different types of vaccine exemptions, being medical, religious, and personal belief, with some states permitting only medical exemptions while other allow combinations. Some states allow medical exemptions only, meaning a child can be exempted from vaccines only for a documented medical reason, such as severe allergies or immune disorders. States like California, Mississippi, West Virginia do not allow religious or personal belief exemptions, and in New Jersey, we allow medical and religious exemptions for school-required vaccines. Vaccine hesitancy should be addressed using motivational interviewing, which is a non judgmental, patient centered way to talk about vaccines. It helps families explore concerns without feeling pressured, and it focuses on empathy, collaboration, and respecting the parent's autonomy, which reduces the resistance and keeps the door open for a conversation. Nurses, as trusted healthcare providers, are key because they interact with families most often and help build the trust MI depends upon. And when the whole care teams models the MI spirit, we create a space where parents feel understood and empowered. This approach boosts engagement, lowers defensiveness, and increases the readiness to vaccinate. Next, I'd like to include some common scenarios that physicians frequently encounter in clinic when discussing vaccines and highlight how motivational interviewing can be applied to address parents' concerns more effectively and support vaccine hesitance. So, scenario one would be a mother brings her 15-month-old for a routine well child visit. When the pediatrician recommends the MMR vaccine, she appears hesitant and says, I've been seeing a lot online and hearing from parents that MMR vaccines could be linked to autism. I'm not sure if it's safe to give it today. In this scenario, mother brings up a common fear that she's heard online, an autism link with the MMR vaccine. With MI, we start by acknowledging her feelings rather than jumping straight into data. First, I'd express empathy, something like a lot of parents share that worry, and it makes sense you're looking out for your child. This builds connection and shows them that we are on the same team. Next, I'd reflect to what she's saying so she feels heard and not corrected. For example, it sounds like you're concerned that the vaccine might impact your child's development. Before offering facts, I ask for permission. This keeps the conversation collaborative. Would it be all right if I explain what we know from research? Most parents say yes because they feel respected. And then I share the evidence in a calm, clear way. Large studies Well-designed studies have repeatedly shown no link between MMR and autism. The one study that originally made the claim was proven fraudulent and withdrawn, and the lead author lost his medical license. Children who get the MMR vaccine and those who don't have the same rates of autism. The goal here isn't to overwhelm her with data, but to provide accurate information in a way that supports her decision making and keeps the trust going. In this graph, you can see MMR cases rising in 2019 and again in 2025. And that's mainly because vaccine rates had dropped too low. When fewer kids are vaccinated, measles spreads quickly, and even small gaps in coverage can trigger outbreaks. After the COVID-19 pandemic, many families fell behind on routine vaccines, including the MMR. Clinics were closed, parents were hesitant to come in, and overall preventative care just dropped. Because of that, we saw MMR vaccination rates fall in many counties across the country. In 2025, US had the most number of measles cases in the last 30 years. Scenario two would be a mother brings her 2-month-old baby for a routine well visit. When the pediatrician recommends the full set of 2-month vaccines, she appears concerned and says, these are too many shots today. I'm worried this might be too much for my baby's immune system. Can we give some today and wait for the others for a later visit? In this situation, the mother is worried about the number of vaccines at 2-month visit. This is a very common concern, so we approach it with understanding rather than correction. First, I acknowledge her concern. I can see why you want to be careful. Every parent wants to make the safest choice for their baby. This helps her feel validated. Then I reflect her worry back to her so she knows I'm really listening. It sounds like you're unsure whether getting several shots in one visit might overwhelm the immune system. Before sharing any information, I ask for permission. And then when she agrees, I offer the science in simple, reassuring terms. Baby's immune system handle far more every day than what's in the vaccine. They encounter thousands of germs naturally. Research showed that spacing vaccines out doesn't add any safety benefit, and following the schedule means her baby is protected sooner and for longer, reducing the time that they're at risk. The goal is to guide her towards feeling confident in the recommended schedule while keeping the conversation supportive and respectful. One of the other commonly asked questions is, can my child still get a disease after being vaccinated? It's pretty rare for a child to get a disease after being vaccinated. Most develop strong protection. And even if they do get sick, it's usually much milder than in unvaccinated children. Another question that comes up is, can my child get a disease from the vaccine itself? Most vaccines use inactivated germs, so they don't cause the disease. For the few live vaccine, a child might sometimes have mild symptoms, which actually shows that their immune system is responding as it should. There have been concerns from parents regarding aluminum in vaccines. Some vaccines include a very tiny amount of aluminum to help the body build a stronger immune response. The amount is very small, similar to what babies naturally get from breast milk or formula, so it's safe and nothing to worry about. There is also an idea about how natural immunity is better than vaccination. Getting the disease can give strong immunity, but it comes with serious risks like pneumonia, brain damage, deafness, blindness, or even death. Vaccines give that protection safety without exposing the children to those dangers. And then the biggest question is, are vaccines safe? Vaccines go through years of careful testing before approval, and they continue to be monitored afterwards. If any serious side effects comes up, we have active and passive surveillance platforms like vaccine safety data link, vaccine adverse effect reporting system, and the vaccine can be updated or removed. The bottom line is that the diseases themselves are far riskier than vaccines. The idea again would be to apply the motivational interviewing approach with empathy, reflective listening, asking for permission, and providing evidence-based information while answering these questions. Next, I'd like to talk about the Vaccine-Preventable Disease Program, which is a part of New Jersey's Department of Health under the Communicable Disease Services. Its goal is to reduce and prevent vaccine-preventable diseases by improving immunization coverage for people of all ages. A key tool is the New Jersey Immunization Information System, or the NJIS, which keeps the track of immunization records for all children and adults across the state. The perinatal hepatitis B prevention program focuses on preventing Hep B transmission from pregnant individuals to newborns. A very important part of it is the Vaccine for Children program, which provides free vaccines to children who are uninsured, underinsured, or Medicaid eligible. VPTP also monitors vaccination coverage and disease outbreaks through population assessment and disease surveillance, including specialized monitoring for rare conditions like acute flaccid myelitis. For families, the program offers parents toolkits with frequently asked questions, tips for calmer vaccine visits, and guidance on addressing misinformation. For providers, there are training resources on communication and health literacy. Finally, VPTP helps enforce New Jersey's immunization requirement for children in preschool, school, and medical exemption forms for families and healthcare providers. Some community strategies in New Jersey to improve vaccination. Firstly, New Jersey incentivizes children and preschool facilities through the Hot Shots for Tots campaign. Facilities earn gold, silver, or bronze recognition for things like educating parents, participating in NGIS, or hosting immunization events. This encourages early childhood settings to become strong vaccine advocates. Second, the state has immunization coalitions like New Jersey Immunization Network, or NGIN, which brings together hundreds of healthcare professionals and community organizations. They lead research, outreach, webinars, and policy advocacy to increase trust and improve access to vaccines. Finally, New Jersey engages youth directly through peer-led campaigns. For example, the Protect with Me 3+ contest invites middle and high school students to create posters or videos about adolescent vaccines like HPV, Tdap. This peer-to-peer approach makes vaccine messaging more relatable and impactful. These are some parent-friendly vaccine resources. These are trusted resources offering guidance, frequently asked questions and educational material. I would like to mention healthychildren.org from the American Academy of Pediatrics, especially helpful. It offers clear evidence-based information and easy to understand answers to commonly asked questions about vaccine, their schedules, and safety. It's designed to make vaccine decisions simpler and less stressful for parents. In the end, I would like to summarize by saying routine childhood immunization for each birth cohort can save thousands of lives, prevent close to 20 million cases of diseases, healthcare costs by billions, and save billions in total societal cost. And a special shout out to our own Dr. Kumta for her constant encouragement and mentorship. These are some of our references. We'll be happy to take any questions, comments. Thank you.
Thank you both. That was a tremendous presentation, gave us a lot of information, very clearly stated and state of the art. So I really appreciate both of you and the clarity and the amount of information you gave us. Great job. I would like to open it up to the group if there are any questions for either of the speakers. I'll start with one in the chat. You can either place your questions in the chat, or it's a small enough group. Please unmute yourselves, put on your video if you'd like, and ask a question verbally as well. But there's one question that came from the partnership. What if the parent, you mentioned asking for permission before giving information? What if the parent refuses permission to share facts and doesn't want their child to get vaccinated? What would you do in that case, either at that visit or later on?
I always think when I face certain scenarios, like similar to the ones that I presented in the clinic, I would always keep the conversation open-ended, and I would like to know on why wouldn't they want to not take certain information from the providers, or what is their perception of not wanting to know about, and why not wanting to know about the questions. So I think the idea here is to keep the conversation open-ended and give an attempt again. And if not, I think it should be still left open to discuss it during the next visit.
Thank you.
I did want to point out Dr. Emirin very helpfully put in the chat that the hepatitis B vaccine schedule is birth, then 1 to 2 months, and 6 months. I think I had 2, 4, and 6, the 4-dose series, which is actually, I believe, for parents with unknown hepatitis B status. So that's a great correction. Thank you, Dr. Emirin.
You're welcome. And you remember some of our vaccines are combination vaccines. So if they are combination vaccine, there's no need to say, okay, because hepatitis B is there, you won't give it. So you give it. And in those cases, those kids get 4 doses, which is fine. And there's nothing like too much of it. So we're good with that, but the recommended is a 3-dose series. I have a question for Dr. Patel. Do you have any position with regards to dismissing your patients who are unvaccinated, or what would be your approach to such patients?
So I do have, I've faced many scenarios and cases in the clinic where they have outright said no to vaccines. I've also tried to communicate again about the pending vaccines in the next visit, but there have been attempts where I haven't been able to convince them, and then I have had to fill in the vaccine refusal form from the parent and get the signature on it.
I think Shivani, Dr. Ramurin brings in a great point. I think that with misinformation and disinformation, there comes a lot of chaos. And we are seeing this more and more. The AAP stance on this is pretty strong. They don't want anybody being dismissed from practices for refusal of vaccinations. And so the challenge is always to bring the patient back for a second visit to allow for dedicated conversation time centered around hesitancy or so. So the AAP has been pretty consistently recommending that. I think Dr. Schwab would agree. That's the consistent constant message that, they don't want to encourage firing from practice or giving in too easily, but they want to have dedicated time sort of settled for addressing concerns like you nicely presented, and giving the extra time.
I see there's a question in the chat about parents who are concerned about the vaccine schedule. Are there any consequences for delaying or spacing vaccines? Yes, there are. So this is very common, as Dr. Patel mentioned, but the immunization schedule is really formulated to protect children when they are at highest risk for these diseases. So, for example, pertussis is very deadly in infants, and their DTaP is given at 2 months for a reason. Same with Hib, pneumococcal disease. So these are all kind of very important vaccinations to get. And in fact, if we could give all of them even earlier, we would. But it's just about when the immune system is capable of mounting a strong response.
Thank you. Yeah, and I think that we're all facing these challenges on a daily basis in our clinics, in our practices, in the community. And I think you mentioned a lot about sharing information. One of the things that I've noticed too is that just as parents respond to the emotional appeal of misinformation, I think they can also be motivated by emotional pleas and kind of tying these issues into what they want for the best for their children. So our last quarter speaker was families fighting flu, and those were families who had children that suffered either severe illness or death because of a flu infection. And they use their personal stories to try to motivate people in the other direction. And I think so joining those kinds of emotional appeals along with good, solid, evidence-based information is really the combination that we look for to increase uptake of vaccines. Yeah. And you gave us a lot of good resources as well, so thank you. And I'd like to thank Dr. Hassan
Sorry.
and Dr. Emiran too for your mentorship and for joining us today. Rohan, you were going to say something?
I was just gonna jump off your point, Dr. Schwab, is that I think CHOP has in their vaccine education center has this really I don't know if you call it great, but they have a resource where it's just a bunch of stories from parents and people who suffered vaccine preventable diseases, which can be really powerful to read and share with some patients and parents who are just or open to that kind of thing.
Can I add something to the fact that if you have children and your children are vaccinated, it's always a positive to tell them, how seriously you take vaccination and let them know that, look, I am vaccinated, my kids are vaccinated, just like, the idea is to make it as personal as possible so that they understand that this is not just random recommendation. This is something you totally believe in, and you will do everything to protect your own child. And that is the kind of love that you expect that they're giving to their own children without making it look as if they care less for their children anyway. But I mean, it's to make them understand that this is so dear to me that if I will do anything to protect my child through vaccination, I will do so. And for those of us, someone like me who trained in Nigeria, worked in Nigeria, seeing, first-hand cases of vaccine-preventable deaths, I bring it up as much as I can, So that way they appreciate that they're not just talking from an abstract point, And we as providers need to understand that some of this hesitancy is lack of exposure to the real danger, which is the benefit of the so much success we've had with vaccination that has created a lot of complacency, and they don't understand that really this is real. This is real. Many of them haven't seen what even measles is like until more recently that we've seen a few pictures. Nobody has seen tetanus. I have treated children who died of neonatal tetanus. I've treated adults who died of, tetanus. So if you have that experience, or if you have anything close to that kind of experience, do not hesitate to bring it up to your patients. It's always important that they have that sense that you know what you're talking about, you feel it, you understand it, and it's not just an abstraction from somewhere, and that people just want people to be vaccinated, which is the impression they get from the misinformation section.
Thank you. Yes, and we don't need to be shy. I think even though one of your early slides mentioned mistrust of the medical system and mistrust of doctors, that is true, but at the same time, and kind of ironically, patients feel that they have very much trust in their own personal doctor or their own personal healthcare provider. And so they may mistrust the system, but they do trust you as a person who sharing, as Dr. Patel mentioned, empathetically and listening and attentively builds a personal trust that kind of can counteract some of that general mistrust. We had one comment from Emily. Absolutely, I agree. When I share with parents that their infant could need hospitalization in the NICU or PICU from one of these diseases, they often don't realize how serious the illnesses are, and it makes it real for them. So, thanks. All right. Well, thank you very much. Do we have any more questions or comments from the group? All right, well, I'd like to thank you again for joining us. You're welcome to stay for the second half of our meeting, and you're welcome, all of you, to join our coalition and attend our quarterly meetings and working groups as we try to increase immunization uptake in the greater Newark area. It's a very local effort, but that's really where things start and where the real work is done. So I'm going to turn the meeting back over to Leanne right now to begin the second half of our meeting and share with our community partners.
Thank you, Dr. Schwab. Thank you, everybody, for this incredibly meaningful presentation. I'll echo what everybody says in the chat, that this was incredible. So I'm just going to, let me stop sharing. Let me just go into my PowerPoint and share from the start here. I do want to share what our working groups have done. Our working group met last month, the end of last month, just before Thanksgiving. And I do want to shout out our working group because the ideas like this is where ideas like this come from. And I'm sorry, I'm having trouble sharing my slides right now. There we go. Okay. Ideas like this came from our working group, and they have, and it's people like you who share these ideas. So let me go back. Okay, here we go. I apologize for the delay. So our EMIC group met on the 20th, on November 20th. We did talk about the ACIP meetings that are happening this week and updates around that. We talked about what's going on in the community around RSV. We're seeing an increase in RSV infections and difficulty accessing the vaccines. We talked about the implications around that. And we're noticing there are some VFC programs that are closing throughout the state. So we talked about ways we can encourage providers to sign up for the VFC program. As a result, our March meeting, March 4th, will focus on the VFC program. VFC folks from the state will provide a presentation. They'll talk about enrollment and they'll talk about updates. So following this meeting today, I will send out a save the date and create a flyer so we can hopefully share that meeting information throughout the state and encourage providers to sign up for VFC. We talked about ongoing issues around vaccine hesitancy, and we talked about NJDOH resources, some of which were mentioned in the presentation today. I do want to remind everybody that the partnership does have the Teachable platform. Our Center for Clinical Impact has the Teachable mobile learning platform where you can watch EMIC meetings. This presentation today will be on the Teachable app, as well as many other presentations, and you can certainly earn credits as a result. You can share, if you sign up for it, you can share the presentations that you're watching. So more information about that can be found on the partnership website. And then thank you so much for the Protect Me with 3 shout out in the presentation. I really appreciated that. Protect Me with 3 is happening. Students in grades 5 through 12 can submit their entries through January 31st. We have gotten over 60 entries as of today from across the state, as far south as Cape May Courthouse. So we're seeing entries from all over the place. They are incredible. These kids are so passionate and so talented. So definitely spread the word about Protect Me with 3 and do reach out if you have students who you think would want to participate or you want to display the information in your offices. And again, save the date, March 4th at noon. We'll be hearing from the VFC program. It's a great opportunity to ask them questions and encourage our fellow offices to participate in VFC and 317. And that's it from me. I don't know if Dr. Sharp is on the call, Dr. Schwab. I didn't see Dr. Sharp earlier.
Okay, yeah, I don't see her name. She
Okay.
usually manages the second part of the meeting. She's our co-chair from Bessie May Health Center in East Orange. So I can try to handle her role. I don't think I'll fill her shoes with her style, but I'll try. So I would like to open things up at this time to the group. First of all, I'd like to invite each of you, since it is a small group, to please introduce yourselves and where you're from, especially any new members that are joining us for the first time, to help us, since this is virtual, to know who we're joining our forces with. So if you'd like, please unmute and introduce yourselves.
I'll start. I'm Emily Haynes. I'm the Chief Nursing Officer at the Partnership for Maternal and Child Health.
Aish, I saw you unmuted. Okay, and if anyone has any announcements they'd like to make about upcoming events at your organizations, feel free to add that now as well, either in the chat or again, unmute and let us know what's going on. And if not, so we will be collecting your information, and the newsletter goes out to all of you via email. If you haven't signed up for the newsletter or you'd like to, you can do so through the partnership's website. And any announcements that you have from your local organizations or local departments of health can be posted there as well for the group to look at. I wanted to thank Dr. Kumta as well. I know you've been on the call and you're a great supporter of the residents and medical students and the clinical work that happens here in Newark. So thank you as well. So I'll turn it back over to Leanne if you'd like to close out, I guess, if we're finished.
Thank you, Dr. Schwab. Thank you, everybody, for joining us this afternoon. I hope to see you on our March 4th meeting. And again, join our working group. We meet quarterly. If you have ideas on future presentations, we'd love to hear it. So thank you so much. Have a great rest of the year. Have a great end of 2025, and we'll be in touch. Thank you, everybody.
Thank you. Bye-bye.